Hello, everyone. Uh, Today we are talking with Dr. Hina Jawaid. Dr. Hina Jawaid, as you all know, is a family physician. She's based in Pakistan at the Health Services Academy, and she is an associate professor of family medicine. Today we will be talking about communication and consultation skills for primary care physicians, or as we call them, family physician or general practitioner. So, welcome, Dr. Hina.
Thank you. Good to see
So
you.
let's start by asking you, why are we talking about communication and consultation skills in general practice or family medicine?
Okay. Well, as we all know, family physicians or primary care physicians or general practitioners, these terms can be used synonymously. They are community-based physicians providing holistic care to the patients, to the population they serve. And I think one of the biggest tool or the most important tool for general practitioners, qualified or trained general practitioners and family physicians is their consultation skills. In addition to all the gadgets. So we do need a stethoscope, we do need a torch, we do need tongue depressors, we do need the equipment to look into patients' ears and eyes and do the examinations. But in order to develop a relationship, because it is something that is a long-term thing, seeing the patient. We see patients from the time of their birth to when they are elderly. So it is said that a family physician is in contact with the patient from cradle to the grave. So, and during that whole duration, we see them evolve from pediatric age group to adolescent to adults, and in developing a family and then having their own families. And some patients, particularly for chronic diseases, we tend to see them on a recurrent basis. So some patients require follow-up, for instance, those who suffer from mental health problems and those who suffer from non-communicable diseases like chronic conditions, diabetes, hypertension, heart problems, stroke, cardiovascular issues. So I think there is a need to stress on the importance of a comprehensive consultation skill. And it's important to empower the general practitioners, because there are areas of uncertainty as well where we don't know what's happening. And how do we communicate that uncertainty to the patient? There are some gray areas which need further exploration. So how to take the patient on board. So that is why a communication skill and a consultation skill is necessary for a GP.
Thank you very much. I agree with you. It's very important for a GP to have a good communication skill, because if the patient comes to them and the GP doesn't communicate, sometimes here we hear from the patients that, I went to that GP and the GP was looking at the computer all the time, or the GP was rushed and didn't give me much time and didn't listen to me what I wanted to communicate to her. You're right. I mean, I think it's a very important skill for a GP to have it, and I think the GPs trained to on communication skills?
In regions where primary care healthcare system is established and more organized and functional, yes, there are standardized training programs, and they ensure that across the national level, the standards are maintained. However, in some regions, including lower and middle income countries, where primary care system is not well established, we do see gaps in the training. And more recently, not recently, about 2 years ago, we started a form of workplace-based assessment as a modified form, which is called case-based discussions. And what it highlighted was a component of consultation, GP consultation, which is history taking, was deficient in lots of areas. And I'll give you an example in terms of how to meet and greet patient, how to start the consultation, the opening statement, how to build rapport with the patient, and how to rule out danger signs by asking specific questions. So there is a set of questions that need to be asked and explored, including a component called ICE, which is idea, concerns, and expectations. So it's called an ICE because it tells us why the patient is here to see you. Has the patient got any ideas about the illness or the disease or the concern he or she has? Have they got any expectations from you? And what are their concerns? So unless and until you explore that, and there is a way to explore it, if you don't ask the question, you don't get the answer. And sometimes patient doesn't come with a straight to the agenda. They come in with things like, I've got a headache or I've got a tummy pain. But actually they are there for certain other things. And if you don't pick up the cues, either the verbal cues or the non-verbal cues, cues are some of the signs which patient give you. Sometimes they say verbally, oh, maybe there is a reason, or sometimes this happens. So these are the cues where you need to kind of pause and ask more about it. So more like probing and interrogation. I know we all have a format in our brain when we are asking questions, but there are times where we have to hold that format, go into another avenue, and then come out into the mainstream. And you only learn this if you have the knowledge about the different types of consultation models in primary care that are existing. And there are a number of types. There are Pendleton, Cambridge, Calgary method, and so on and so forth. So in places where primary care is established, teaching of the models is also important. It's incorporated into the curriculum. If not in detail, then briefly. So students, the trainees, they get an idea. Yeah.
All right. Thank you very much for your detailed answer. I think let's talk about the golden minute. Would you tell us what is a golden minute and why is it important?
Okay. So the golden minute is the first minute of a general practice consultation. If I say that the entire general practice consultation is 10 minutes duration, we divide the 10 minutes into 3 components broadly. So the first component lasts for about 3 minutes, the next one, 3.5, and then the last one, the remaining of the minutes. And if you divide that, the first 3 minutes, the first minute of that 3 minutes is the golden minute because you are now allowing the patient to talk. And as a doctor, you are going into the listening end. So, and the studies have shown that if you allow the patient to speak for not even a complete minute, say 30 or 40 seconds, you will get an idea why the patient is here. Because patient will tell you all the information that they are there. And once you have got that agenda in your hand, then you will be able to ask the subsequent questions. And one of the other things I tell the trainees is, if you establish the duration of a patient's symptoms, any symptom could be, that will also guide you. Say a symptom like headache, whether it's been there for years, or a headache which started a week ago and now getting progressively worse. There's a difference. You know what your strategy can be right in the beginning, and then you can taper your questions accordingly. So golden minute is listening to the patient in the first minute.
All right. I'll ask this thing a bit later about the type of questions that you just spoke about. But let's move to the components of general practice consultation. So what are, like you just said that there you break into 3 different sections or components, but are there anything else that you want us to know about the components of general practice consultation?
So yeah, so we talked about the first 3 minutes. So in the first 3 minutes, you obviously meet and greet the patient. You ask the patient what brought you here today, or how may I help you today? And then once the patient start talking, you try and establish, as I said, the duration of the symptoms, any features associated with it, which patient would have told you in that 1 minute when you allowed him. So it kind of helps you get the information quicker. And then you can filter in your mind what would your next question be? And then the most important thing, first you ask open-ended questions, which give you the broad information, and then you ask for close-ended questions, which give you the specific information. And I'll give you an example, like if somebody comes in with a headache, you ask them questions like, are you getting any vomiting or nausea with it? Are you getting any visual symptoms, double vision or blurring, for instance? Are you throwing up, vomiting? Is your headache worse in the morning, like thunderclaps headache? And that gives you an idea about severity of the condition, because you need to know in the beginning what my strategy would be in the next set of 3 minutes. What systems am I going to examine? For example, in case of headache, you would like to do the general examination, which means checking the pulse, blood pressure, oxygen saturation, temperature, if there is a history, and obviously examination of the eye and the vision, and then the cranial nerves, the central nervous system examination by making the patient walk, checking for coordination and different movements, and the cranial nerves which supply the face and the rest of the body as well, which are important for us. And as I said, examining the eyes as well. There could be lots of reasons for headache. It could be a referred pain. It could be related to an infection. It could be related to having any cerebrovascular accident. Check the patient's medications, which you've already done in the first 3 minutes when you're gathering the data. What medications is patient on? In places where the systems is digitalized, or where we are keeping the records, even the manual records, we have a list of patient's medications in the previous consultation, so we know what the patient is on. But it's always important to check, has the patient started any new medication, is buying any over-the-counter medication, has he had any injury to the head? Because it's best to check, or not always cross-check, never assume anything. So the first 3 minutes, by the end of the first 3 minutes, when you have asked all the questions, you should have some differential diagnosis in your brain that I'm dealing with A, this condition, B, that condition, C, depending. And your examination will then either confirm or refute your findings, and then your list will shrink. And by the time you come to the last 3 or 3.5 minutes, that's where whatever you have gathered, the information through asking patient, you will be utilizing it in the end. So you'll say to the patient, oh, I've asked you questions and I've examined you, and I had been thinking about this and this and this. However, after examining you, I think I can rule out safely so and so. However, I need to carry out further tests to make sure we are safe before I send you home, or I need to establish whether you need to be referred. And again, whenever you tell the patient everything, whatever the treatment options are there, you can give the treatment options to the patient. Maybe patient has got some preference. Maybe the patient already knows what's happening with him. Because as I said, exploring the idea, concerns, and expectation earlier in the consultation will help you establish. Patient may come and say, oh, one of my relative died of a brain tumor, and he complained of headache. And patient expectation would be, can I have a CT scan of my head or MRI scan of my brain?
Right.
So once you know that, then you are better able to deal with it. And also having the knowledge gained through evidence-based medicine is important, because if as a GP you have got the evidence-based backup, then you will be able to offer the options to the patient and encourage shared decision making. And always remember that the last two things that I always say to trainees is, always follow up your patient. It's always good. Patients also feel good and valued, and they regard that, oh, the doctor is really taking my care and care seriously. And safety net. When the patient is leaving your clinic, make sure he or she knows what to look for. So if the headache is getting worse, they start throwing up, any double vision or blurring, they feel unstable on their feet, or any other features like fast breathing, pains in the chest, weakness in the arm. So they need to know what to look for. And if there's any worry,
Mhm.
they come back or contact the hospital.
Okay. Yeah, that's quite informative. So asking the patient, so not only providing the information to the patient, but also discussing with them the treatment options. You did mention shared decision making. What do you mean by shared decision making?
Okay. If we simplify this and say we all like choices in our life, we like to choose from this and that. And providing, and I understand not every condition you have a choice,
Mm-hmm.
but there are a number of conditions where you have the choice. For instance, I'll give you an example. If somebody's suffering from mild anxiety or mild symptoms of depression,
Mm-hmm.
and you do the PHQ-9 scoring, which is a test for it,
Mm-hmm.
and they're scoring low in it. So you tell the patient, look, you fall in this category.
Mm-hmm.
Here we have got a few options. Um, you can either see a counselor,
Mm-hmm.
have the option of, which is a non-pharmacological treatment.
Mm-hmm.
You can have the option of cognitive behavior therapy.
Mm-hmm.
And again, cognitive behavior therapy, you've got a self-help option, or if you want to see somebody.
Mm-hmm.
And things like sleep hygiene, where you look after the environment where you sleep, make sure you don't have a heavy meal before going to sleep, you wear comfortable clothing, the surrounding is quiet and peaceful, and things like that. And then there are medications available as well if you wish to, and there are therapies. So patient has a choice. Some
Mm-hmm.
patients say, no, I don't like counseling. I think I'll prefer the online CBT. I don't like talking to a stranger and things. So
Mm-hmm.
they have a choice. You can
Okay.
also provide them information links or leaflets.
Mm-hmm.
One of the common ones I use is a patient.co.uk, is easily available, accessible. It's free. You don't need registration. There's no cost attached to it. And it provides credible information. And it has got sections for healthcare professionals and the ones for patients which do not use medical jargon. So once those patients who are able to read and write and who have got access to internet, they can just type in the comfort of their houses and then go through the details. So once patients are more informed, they make a better choice. So yeah, and there are conditions where we don't have to make a decision there and then. There's always some time. You can say to the patient, why don't you read about this and come back and we have a chat, and then we can decide which option suits you better. Same goes for things like different forms of contraception. So a female which is starting contraception for the first time, there's a lot of information and it's difficult for them to digest in that 3 minute or that of we have. So it's better to back it up with some written information, give them leaflets, ask them to come back once they have read it, discussed with the partner, and then decide, and so on and so forth. Yeah.
Thank you, Dr. Hina. Okay, you mentioned something about holistic care earlier on. So, what is holistic care, and how can we conduct holistic care in Pakistan or in low middle income country setup?
Okay, holistic care means seeing patient as a whole. So not just
Mm-hmm.
the physical illness, but the emotional side of things as well. And
Mm-hmm.
remember, all chronic diseases have the element of mental health
Yeah.
issues related to it.
Mm-hmm.
There, somebody who's long-term diabetic, who's ongoing diabetic, particularly if it's poorly controlled, you have to explore the reasons. And one of the reasons could be comfort eating, because they want to feel good.
Mm-hmm.
Um, so just wherever you think arthritis, rheumatoid arthritis is another one, even osteoarthritis,
Mm-hmm.
it takes away patient's freedom, the mobility. Maybe the patient is up all night because of the pain and needing painkillers and now having side effect of painkillers.
Mm-hmm.
So they may keep coming back to you saying, I still have got joint pains. There is no medication that's suitable for me. I need a stronger painkiller. I'm not happy with my doctor, and so on and so forth. So whenever, and that's what brings us to some of the other topics, like how to deal with aggressive patient, how to deal with angry patient or difficult patients. You always have to identify why the patient is reacting in the way they are. And is there something else going on? Do we need to actually take a pause from their physical problem and what they are saying to, and divert the conversation to, is there something else you want to talk about? So there was a case where an 8-year-old, her mother has been bringing her with symptoms of headache for almost 2 years. And that young girl had most of the investigations that could happen, including a CT scan of the head, in addition to the blood test, to find out the cause of headache. And after 2 years, one of the doctors, one of the GPs, who was actually doing the consultation, they picked up some of the cues that led them to ask more questions. And it turned out to be that girl had a behavior issue.
Okay.
And in 2 years, it was the first time that the mother got the chance to talk about it. And that had affected the entire household. The other siblings, parents' life, the girl had become too controlling, her studies was getting affected, and she had lots of anxiety as well. Like, despite reassurance from the mother, she wouldn't calm down. Like, if they had to go to, there were 3 kids, if they had to go to school, she would get ready on time. And if the siblings are getting late, she would start screaming and shouting and tell the mom, all the mom would reassure that I will take you to school on time. But no matter whatever sort of reassurance you would give her, she wouldn't calm down. And it's a very complex case, and you need multiple disciplines. So it's always important to pick up cues. Sometimes patients are not saying that through their mouth, or by not verbalizing it, but their actions may show it. So it's good to have a good observation. Yeah.
Okay, so so the message is that when the patient comes and talks to you, do not treat only that symptom, but look for a whole of the picture and try to understand what is not being told to you. There may be some other things that the patient may that there is some other thing that you may explore and reach a better decision making. What So this is all good, Dr. Hina, but in Pakistan, where so you mentioned about an 8-year-old girl, but in Pakistan, even adolescent girls, even married women, they come with their spouses, and in our society, so communication is a big issue between the GP and the patient, especially particularly when the GP is a male and the patient is a female, or if the GP is a female and the patient is a male. And when they have their some person sitting there with a power dynamics in the family. So how do you deal with that?
Right. Okay. Now that's a very good question, because look, and I've been doing the communication consultation skills workshop since 2017, and we get lots of questions like these and similar, like violence in the hospitals, doctors getting involved, and all that. So, and some of our students have even brought videos of the incidents, and we've kind of tried to explore what we can learn from it.
Yeah.
If you practice a standard method of consultation, and if you do a standardized clinical practice, then you would be able to handle the situation. The confidentiality, patient's privacy comes first. And I'll give you an example. When I see newly married couples, what happens is, when there are 3 people who come into the clinical room or the assessment area, and one is a mother-in-law, one is a couple itself. So 9 out of 10 times, the male partner goes out of the room, and you are left with the lady in question, which is a patient, the wife, and the mother-in-law. And then you are faced with questions, oh, doctor, she's not having a child. So presumably an infertility issue. And then you have to ask questions. How long have you been married? And well, there are certain questions that you can ask in front of the third party, but there are certain questions which are intimate and you cannot ask. Maybe the female, the patient herself, wouldn't even want the husband present, let alone any other relative. So and these are the areas where you have to, now there are ways of dealing with it. Once you've realized what this consultation is about, you can ask the patient, would you like the relative to be present in the room? Are you comfortable? And give her the option. If you're not comfortable, I can request her to stay outside. But
Mm-hmm.
you have to be very, very polite. We are not here to intimidate anybody. We are not here to disrespect anybody, but we have to kind of give the impression that we have the patient's best interest. You can explain to the third party, say, the patient may not be comfortable answering some of the questions.
Mm-hmm.
And I understand and appreciate you've taken the time out to visit me in my clinic, and I want to do the best for you.
Mm-hmm.
And I want to really help you deal with the problem. And I will invite you once we have asked the question, so I can listen to whatever you have to say. Or
Mm-hmm.
if you want to tell me now, you can tell me now before I move to the patient. So give the third party enough respect and allow them to talk as well. Maybe they want to tell you something. So
Yeah.
you can always listen. You don't have to act on those. But the final decision or the ultimate decision has to be the patient. Uh, and you have, as a doctor, you have that position of responsibility where you can actually not even verbalize it, but implement that as well.
Mm-hmm.
And it will help you with your subsequent visits. And
Yeah.
if this patient wants to come back to you again, she will now know that she can go and have a one-to-one conversation with you. And the third party would know that going in again would require permission or some form of a settlement, maybe. But you have to break the cycle at some point. And if
Yeah.
most of the doctors start doing it, then the message will go out there. Yeah.
Yeah. Yeah. I mean, I've been in certain situations where the patient, you're asking the question from the patient and the mother-in-law is answering, and then you'll be it becomes quite unpleasant situation. Any other challenges that you face while communicating with the patient, and any other suggestions to overcome those, particularly in Pakistani,
Um,
when you're dealing with Pakistani patients or people from South Asia?
I think because of the way our culture is, some of the topics can be very sensitive. For example, when I've seen through the case-based discussions over the past 2 years, particularly, we used to conduct more than at least two, or sometimes more than two online case-based discussions per month. So they've been a good number. We as doctors, maybe because of the training component wasn't there, we are not very forthcoming in asking a detailed history,
Yeah.
particularly the sexual history.
Mm-hmm.
And there may be some uh, lack of initiative or confidence from the doctor's part.
Yeah.
Remember, if doctor is not going to ask, the patient is not most times going to volunteer.
Mm.
Sometimes they may tell you something else which may not be relevant, but you have to bear that in mind, that
Yeah.
there could be similarly child abuse cases, extremely difficult. And the one thing that I find difficult is signposting, because there are not many services that we find where we
Mm.
can send patient for support, like parent support or the child support.
Yeah.
Difficult to include schools, teachers, keeping things confidential,
Mm.
particularly for infectious diseases, sexually transmitted diseases, because of the social taboo. And but obviously you have to tell the patient that you are able to go as far as possible to safeguard if they things and help them.
Mm.
So but can get difficult. But I think patients do understand, and systems do support you, but you have to kind of push the
Yeah.
boundaries a little. Yeah.
Yeah, I mean, it is challenging for the doctor also, to talk to the patient about sensitive issues, and especially if they are underage or if they are from the other gender. Um, I think we have uh, completed all the questions.
Mhm.
You were talking about ICE earlier. Do you want to elaborate a bit more on ICE?
Okay, ICE, which is I stands for idea, concerns, and expectation,
Yeah.
is an important component of general practice consultation.
Mm-hmm.
It is better to identify it earlier in the consultation because then it helps you address it towards the end.
Mm-hmm.
Uh, Again, idea, concerns, and expectations is something which you can only develop in your consultation if you had the training of it.
Okay.
What I tend to do in the workshops is once we have covered the theoretical aspect of it, we move on to things like role plays.
Okay.
So patient doctor simulated patients, and
Mm-hmm.
we time it. We time the consultation.
Right.
And and that gives a idea to the person who's performing it and people who are observing it, because then we tend to get a feedback
Mm-hmm.
from the audience. And it's you can only kind of you can read about it from the text, but unless and until you perform it,
Mm-hmm.
and it's not part of your habit up to that point where you came for the workshop,
Mm-hmm.
then incorporating it in a short period of time, say a workshop can last for 3 days maximum or 5 days.
Mm-hmm.
So you have to practice it, practice it, practice it. You can only practice it if you make a mental note of it.
Yeah.
Uh, and yeah, so it. I always tell my students, you are the director of your own consultation. Your brain has to constantly filter out what is important, because patient gives you a lot of information,
Yeah.
but you have to decide which information is important
Mm-hmm.
and how you will format the next question and ask what is your line of action or direction of your action. So you have to, and that comes from practice.
Yeah.
And yeah, so when I give them a task to, whenever go back to your institutions, practice it and make a conscious effort. You have to be aware of it.
Yeah.
You can't let go, otherwise it will fall into pieces. You won't be able to. You'll miss out on the things.
Yeah.
A lot of times, uh, people come in with chest pains, and when I've reviewed them, and they'd been to other doctors, they even had angiography.
Mm-hmm.
And probably nobody asked them the question, do you suffer from low mood symptoms,
Mm-hmm.
depression?
Mm-hmm.
How has your mood been? Do you become tearful, irritable, angry? Any thoughts of harming yourself? So maybe these questions were missed during the previous consultation somehow. And
Mm-hmm.
it turned out to be a case of anxiety rather than any cardiac problem. So we can I mean, we can cut down on a lot of expenses. See, this patient never needed an angiography in the first
Yeah.
place if she had been managed. So you can cut down the cost with a robust, trained, qualified primary care physician.
Yeah. And I think it should be incorporated, the communication skills and counseling should be incorporated. It is an important part of history taking. It's just
Yeah,
that the students are not properly trained on how to incorporate these. So,
yeah.
what are your uh, three takeaway messages that you think that two or three takeaway messages that you think are important for your listeners?
Okay. As I said, always have a mental note of the three uh, components of the consultation.
Mm-hmm.
In the beginning, when you're practicing, time it. You should be able to reach some form of a diagnosis in about 3.5 minutes, not longer than
Okay.
that.
Mm-hmm.
If you're not able to reach there, then just revise and review where you are, where the gaps are.
Mm-hmm.
Always allow patient to talk first. That will make your life a lot easier. Listen to the patient, and yes, make an eye contact. I know there are places where there are computerized systems and we are trying to look at the patient details and check the past medical history and the medications. And patients also do understand that, but do make an eye contact, do nod, do show gestures, the non-verbal, indicating that you're listening.
Yeah.
Yeah. And particularly when you are towards the end and you're managing the patient now, make the most of the eye contact then. I wouldn't ask you to stare at the patient, but make enough eye contact in a respectable manner.
Mm-hmm.
And yeah, evidence base is important. Make sure you're up to date with your knowledge and skills. Um, there are patients who can be a learning resource for us. Sometimes when they walk out of our rooms, we realize, oh, I didn't know that topic very well. I'll go home and read about it, or I'll explore more. So use your consultation as a resource to identify your gaps, because the learning continues as long as you're practicing.
Mm.
So, yeah.
So one last thing, so you were mentioning about the communicate the flyers that you give to the patients and all that. Are there flyers available in Pakistan in the local languages?
Oh, yes, they are. Some are really good, actually. They may not be easily available, but you have to look out for them. So if you are in contact with a specialist,
Mhm.
if you're in contact with family planning clinics, then
Mhm.
they are the good resources they can help you provide. Sometimes you can even find it in the local regional languages as well.
Right.
Uh, some areas it's quite well defined. So
Okay.
it's basically networking and finding out the different resources that are available. As I said, they may not be easily available, but you'll be able to find them sooner rather
Okay.
than later.
Yeah, that's good to know because often patients, the doc GP has very little time, and the patient do need something to take home and then go about it. So it's good to know that there are resources available in Pakistan. So thank you very much, Dr. Hina. I think we have covered the communication and counseling skills, and we will talk again pretty soon about another topic. Thank you very
Yeah,
much.
no worries. Thank you. Bye.
Bye.